Okay.
Marcus, I have a question. Like, I think someone just asked before, but I don't think I got clear on it. So the Lees fracture, the ligaments, once you put the screw down, are they gonna like connect themselves together, or you kind of need to physically connect them together during the surgery process?
The ligaments will connect themselves back
Like,
together.
like they will just come together and heal. Okay.
So today I will be presenting a case study on an Achilles tendon reconstruction. So here's just a little background information about the prevalence of Achilles tendon injuries. Of 100,000 lower leg injuries, 18 Achilles tendon ruptures are accounted for. Also, acute ruptures in athletics consist of 68% of all Achilles tendon injuries. So to review the anatomy of the lower leg, it is important to consider the bony anatomy at the knee and ankle joint, as depicted here in this first picture. And it is also important to consider muscles assisting in plantar flexion, as depicted in the second picture, and muscles assisting in dorsiflexion as well. And then this slide just depicts the posterior view of muscles aiding in plantar flexion. So here we see that the gastroc narrows down into the soleus and then forms the Achilles tendon as it attaches to the calcaneus. So the Achilles tendon is considered the strongest and thickest tendon in the body that acts to stabilize a person's body weight. The main purpose of this tendon is to attach the gastrocnemius and soleus to the calcaneus. When the calf muscle flexes, the Achilles tendon then pulls on the heel to promote plantar flexion, which often allows the transition from the heel strike phase to the toe off phase during walking, running, and jumping. There are many thoughts as to why the Achilles tendon ruptures during sport. It is often thought to be due to inherent characteristics, function, or even the blood supply to the tendon. Also, it is considered due to inflammatory changes or degenerative changes within the tissue that the rupture does often occur. So these changes could be accounted for through Achilles tendonitis or use of corticosteroid injections. Training errors also account for some ruptures as well, so these could be an increase in activity, changes in training surface or schedule, or even the use of improper footwear. So overall, the ruptures usually occur during a strong dorsiflexion force to the ankle as the gastroc soleus complex is contracting eccentrically to plantar flex the ankle. So this particular athlete is a 20-year-old Division III designated hitter for the Linfield College baseball team who has had an extensive past history of Achilles tendonitis complications over the last 2 competitive seasons that has gone untreated due to lack of rehabilitation compliance to his program. So in October of 2016, during the non-traditional sports season, this particular athlete was running late to practice one afternoon and therefore decided to skip his warm-up and jumped right into a scrimmage at practice. During his at-bat, this left-handed hitter was focusing on loading more of his weight into his back trail leg, so his left leg, to have a more explosive pivot. As he pivoted out of the batter's box, he felt an initial pulling sensation in the back of his left heel that he ultimately thought was going to relax as he continued to warm up and as practice went on. So he decided to continue base running at this point. Once he was at first base, he then decided to have a more explosive toe-off phase to promote his base running. So upon this movement, he felt an increased pulling sensation as he transitioned from a side shuffle to a sprint. Unfortunately, the athlete then overran third base and had to make a pivoting motion to get back to the bag. Upon this motion, he caught the edge of the bag in a dorsiflex position with all of his weight loaded into his Achilles, and upon impact, he heard a nice pop. So after the injury happened, he was in severe pain and saw the athletic training staff approximately 10 minutes post-injury. Upon ATC evaluation, a muscle tissue nodule was palpated in the gastrocnemius, as well as a depression noted approximately 2 inches above that calcaneus. The athlete was unable to actively plantar or dorsiflex at this time, and a positive Thompson test was reported. Manual muscle testing was also performed at this time, and the athlete was only able to perform a 2 out of 5 for that scoring system. Since an Achilles tendon rupture was suspected, the athlete saw the Linfield College sports medicine doctor the following day, and there he ordered an MRI. Once the results came back, it was indeed decided that he had torn his Achilles tendon. So he was then referred to a sports medicine doctor who specialized in ankle and Achilles surgeries. So surgical intervention at this time occurred 8 days post-injury. The surgical intervention chosen for this particular athlete was a minimally invasive surgery technique created by Malufi. And this method was chosen just due to increased rates of healing, shortened recovery time, and an overall decrease in risks of any complications with the surgery. So the surgery was performed by making a 1 centimeter transverse incision over the nodule, followed by 4 longitudinal incisions approximately 6 centimeters medial and laterally to the palpable nodule. Following these incisions, a Maxon suturing process occurred in a transverse pattern that mimicked the shape of an hourglass. After the threading process was concluded, passive plantar flexion was applied to the ankle before the Maxon threads were tied in a double throw knot. Throughout the entire surgical process, the sural nerve was protected. So here's just a picture depicting the surgical sites over the nodule, and then this was the Maxon threading process that occurred in that hourglass pattern. So the ultimate goal of rehabilitation was to have the athlete cleared and return to play approximately 6 months post-surgery. This phase, or this process, was broken down into approximately 9 different phases that allowed the athlete to complete training sessions 3 times a week. So our primary goals of phase 1, which occurred during weeks 1 through 3, was to decrease any pain, discomfort, and acute injury symptoms post-surgery. So modality treatments during this phase were just your regular ice and E-stem with game ready and elevation. The patient was also to remain non-weight bearing in a boot and use the crutches and the scooter to assist in immobilization. The athlete also received a home exercise program consisting of rices for an additional 2 times a day. As we progress to phase 2, weeks 3 through 12, the primary goals of this phase were for the athlete to complete non-weight bearing linear exercises that gradually progressed to weight bearing proprioception exercises throughout the duration of this phase. So exercises include towel scrunches, marble pickups, and then we gradually progress to double leg balancing exercises. Our other goals were for the athlete to complete a manual muscle test of 3 out of 5 during this phase, and at week 7, we would like the athlete to complete dorsiflexion to neutral, 30 degrees of plantar flexion, 20 degrees of inversion, and approximately 10 degrees of eversion. At this time, the athlete was able to complete all of these goals. In addition to our other RICES treatments, modality treatments including ultrasound and Grafton were included for scar tissue mobilization as early as week 6. In phase 3, weeks 12 through 14, we transitioned into single leg balancing exercises and open kinetic chain exercises that included hamstring curls and exercises of that nature. The athlete was also permitted to start walking short distances out of his boot, mostly during rehabilitation training sessions, but was also allowed to start walking around his house without his boot. Our main goals during this phase were for the athlete to complete 15 degrees of dorsiflexion and have plantar flexion equal to the opposite side. And the athlete was also able to complete a manual muscle test for plantar flexion of 4 out of 5 during this phase. For modality treatments in this time period, we transitioned into more joint mobs for the subtalar and talocrural joint to increase our range of motion, and we added an ankle PNF in the D1 and D2 patterns to strengthen the ankle through all planes of motion. During phase 4, we were able to start implementing sport-specific dynamic warm-up and some more functional activities. So exercises progressed to more functional movements such as ladders, lunges, step downs, and lateral steps. These exercises all were performed at a moderate difficulty and under a low intensity output. The athlete was also able to be full weight bearing approximately week 16, and a manual muscle test of 5 out of 5 was performed at this time, and joint moves and PNF patterns continued throughout this phase as well. So as we implemented more of that sport-specific activity, a sprinting protocol at approximately 50% of the athlete's maximal effort was implemented. These were build-up, build-down progressions in a linear fashion. So we really focused that the athlete gradually progressed to speed and then had his highest amount of speed during that middle phase and then slowly progressed back down. So there wasn't a dead start and a dead stop. So the athlete during this phase was also able to hit off of a baseball tee in the cages for approximately 20 minutes, 3 times a week. But fielding drills were not incorporated in any of the athletic training, fielding, or rehabilitation program due to the athlete being a designated hitter. As we were progressing through the later stages of rehabilitation, our functional exercises were increased to incorporate more of our closed kinetic chain exercises that mimicked activities that he would complete with his teammates. A plyometric training protocol at a lower difficulty level and moderate intensity level occurred during this phase as well. And our sprinting build-up, build-down progressions were progressed to approximately 75% of the athlete's maximal effort. During this phase, we really started to limit our modality use, and the athlete completed heating before his dynamic warm-up and icing following his static stretch at the end of his training days. In weeks 19 through 20, plyometric exercises increased to a moderately high level with the difficulty level increasing to about medium. Our linear sprints limited our build-up time during this phase, but still incorporated that long build-down progression. And we also started to incorporate some multi-directional movements consisting of line hops and things like that nature. The athlete at this time also participated in live hitting drills with approximately 75% of his maximal effort accelerations to first base for 45 minutes. The athlete was not continually hitting during this time due to other teammates participating in the drill as well. So there was approximately a 3 to 5 minute break in between each of his repetitions. During phase 7, this was the phase right before we did our functional testing, 100% of his sprinting protocol was achieved. So during this phase, he was no longer building up and building down, but he was still able to complete that at 100% of his maximal effort. Accelerations to first base were also increased to that 100% maximal effort, and he was also at this point hitting off of live pitches. And lastly, our plyometric activities increased to a high level and a high intensity. So this was the highest level that the athlete was training at throughout the entire rehabilitation program. In weeks 23 and 24, the athlete was progressing to functional return testing, which occurred at the end of week 24. The athlete had to show that he was able to complete testing drills on 2 consecutive training days at full strength and under maximal effort with proper range of motion, mechanics, and so forth. So these testing drills included a T-test, a pro agility drill, a box drill, and different ladder agility work. The athlete was also ready to return to play at the end of this week 24 when the entire sprinting and hitting protocol progressed without any pain and under full strength. Throughout the entire rehabilitation protocol, the athlete completed core and cardiovascular training to maintain his core stability and cardiovascular endurance. So these exercises began in the early phases with non-weight bearing seated activities that further progressed to more weight bearing activities just to limit that stress amount on the Achilles tendon. Cardiovascular training during this the whole time began with upper extremity biking intervals and aqua jogging that then later progressed to more biking, walking, and jogging activities. The athlete overall was able to complete all of these activities without any major setbacks. So in conclusion, it is important to treat inflammatory conditions within the tendon when they present themselves to further prevent ruptures from occurring. It is also important to correct any training errors that ultimately may increase the athlete's chance of injury occurring as well. For some reason, if a rupture does happen, it has been determined through research that a minimally invasive surgery increases the athlete's chance to return to play at a quicker rate. Any questions?
Is there a specific site or a pattern on the place where the Achilles ruptured? Say, if it's where the tendon attached to a calcaneus, or it's where the tendon attached to a muscle, or it's more like medial tendon.
So it's usually at the narrowest point of the Achilles tendon, which is approximately 2 to 6 centimeters from the insertion point on the calcaneus.
Pretty early, I believe it was like 5-6 weeks post-surgery, you started hamstring curls, you said?
Mm-hmm.
Am I right there?
Yeah.
Were you worried about the Achilles tendon since the gastrocnemius is a knee flexor as well? Were you worried about damaging the Achilles tendon because you're working the gastroc?
We were, but during this phase, we were just starting the open kinetic chain exercises.
Okay.
So these were performed with very low weight and at a very low intensity, and we really monitored how the athlete was feeling throughout the course of those exercises, just to moderate how much force we were putting on that Achilles tendon at the time. Yeah.
The studies that you read, did a lot of them present cases of people tearing their Achilles tendon after having Achilles tendonitis and Achilles tendon issues? Was that a common thing, or was it mostly just like acute right off the bat?
For most of the